My name is Kathleen Sciacca, and my discipline is in clinical psychology. I'm the executive director of Sciacca Comprehensive Service Development for mental illness, drug addiction, and alcoholism. And I began that work as the director of the MICA training site, which I was for a number of years, for the New York State Office of Mental Health, where I initially developed the first interventions for what is called dual diagnosis or co-occurring mental illness and substance disorders. And I held that position for a number of years and then went out to be self-employed. And since that time, I have been a consultant and a trainer and a program developer for many states around the country, the statewide for the state of Georgia, for Tennessee, for Michigan, and then I've been, county-wide, city-wide for Washington, D.C. So my career took a whole different path as a trainer, program developer, program implementer, which led me to develop clinical materials, program materials, curriculum, and training. In about 1992, I learned about motivational interviewing, and in 1995, I formally became a motivational interviewing trainer and a member of the MINT, which is their network of trainers. And I have been teaching and training motivational interviewing along with dual diagnosis program development and separately from that. And I teach that to many different disciplines because motivational interviewing, although it started in the addiction field, has really spread out to many fields of behavior change: criminal justice, smoking cessation, gambling, primary health care, education. So I teach sometimes multi-groups, or I'll be invited to teach a specific homogeneous discipline to do motivational interviewing. I'm an author. I've written quite a lot on a number of different topics. I'm an educator. I've taught and guest lectured and taught different courses in colleges and universities. And I'd like to talk today about the use of motivational interviewing in psychiatric care. Okay, one of the really important parts of a relationship in psychiatry is the engagement of the client into a trusting atmosphere where they can speak the truth about their situation. So the practitioner follows the client for a while and reflects back what they hear them saying and tries to understand them and convey back to them that they understand them. This process of reflective listening is the work of Carl Rogers. And it's very empowering, it's very engaging. It gives the person, the client, certainly the experience that someone is listening to me. They're really trying to understand me. They're conveying that they understand what I have to say, and that what I have to say, what my experiences are, what my feelings are important. On the other hand, the authoritarian response tends to shape all of that out. It really has to do with, which can be very legitimate, that the psychiatrist has a lot of information that could be very helpful to the client, a lot of medications that might be very useful. But if they're done in an authoritarian way, whereby it's sort of telling versus listening, the client is not as likely to be listening to it or to be engaging that information into their own issues. So that collaboration becomes an essential element. First, one wants to begin to engage the person with collaboration by asking them open questions that lend them to talk about what's going on for them, so that the practitioner has a place to follow along and give feedback that is really an attempt to let the client know, I understand why you feel that way. I understand why you perceive it that way. I'm understanding what you say. And one cannot give enough credit for that. It's so validating. The person hears, feels listened to, understood, and it allows the person to go further into that process. The practitioner, from that point of view, becomes a mirror for the person. So the person may now begin to say, well, I did say that, but what did I really mean? And then they begin to examine what they said. And they might find other little pieces of parts of it and say, yeah, that's true, but also, this is also a part of it. And then the physician would the practitioner would reflect that back and they would begin to really get into a dialogue which has nowhere to go except further into the client's experience of these issues, the issue being discussed, unless the client decides that they don't want to talk about it anymore. And that's another very important listening skill for the psychiatrist to have. When the client sort of shuts down or goes back to something they were talking about earlier, and a motivational interviewing, one needs to be able to pick that up, that's as far as we're going, that's as far as the person is going here, and move off on to another place. So, well, what else would you like to talk about? That seems like one part of it. Is there anything else you'd like to say? So that is really another very important listening skill. So one is in reflective listening, listening for the person's feelings, experiences, perceptions, and trying to convey those back accurately. And the other is to let the client know that what they're saying is important and matters, and we need to be hearing this. So an authoritarian response can shape out the client's thoughts and ideas and perspective, and actually sort of shut them down. We call roadblocks in a way. Sort of stop me from talking because what you have to say is more important, and I really stop sort of listening to you, or I stop talking to you. What I want to make very clear is that authority and an authoritarian approach is not to be confused with expertise. The psychiatrist does include all of their expertise, everything they know in the field, everything they have to offer the client, but it's done in a collaborative way, and that's another very important part of collaboration, whereby rather than saying, this is the medication you have to take, it's the only thing that's going to work for you, and giving direct advice, one perhaps asks permission. Would you like to know, about the medications that could possibly work for you? And if the client says yes, then the doctor might give examples and reading material for the person to take a look at, and then ask them what they think about it, how they think that might work in their case, so that the information, expertise, and authority are two different areas, distinctly different. And the expertise is in partnership with the client's knowledge about him or herself, what they're willing and not willing or able to do, and the doctor's information about what might really work best, and in lieu of the client not being willing to do that, what other alternatives they might look at, but it becomes always a collaboration. But I just want to make it clear that the authoritarian stance is different from expertise, whereby it really has to do with the communication style. And the authoritarian approach is where one is simply just telling, without collaboration, without really doing very much listening. And that tends to shape the person out of the process, and probably will result in a non-adherent kind of relationship, or a discordant relationship. The word resistance has generally been used to describe what one is looking at as discord. So one might put it this way, that the communication style in motivational interviewing and using that style of collaboration is a relational process. It has to do with our relationship, how I respect you, how you respect me, whereas the expertise has more to do with the technique and the technical information that needs to be imparted. So they're both relevant, and it's how we impart that information with the motivational interviewing communication skills that makes the difference here.